Assalamualaikum. My name is Kishwar and my roll number is EB1770070 and my group number is 24. The topic of my group is adverse effects of chemotherapy and targeted agents, and the subtopic allotted to me is specific organ toxicities. Starting from specific organ toxicities, in these toxicities, some organs are affected due to chemotherapy. These organs can be the brain, heart, lungs, kidney, etc. The adverse effects of chemotherapy can be classified as common and acute toxicities, specific organ toxicities, and long-term complications. Specific organ toxicities often are attributed to a unique uptake of the chemotherapeutic agents by the organ or as elective toxicity of the agent to the organ. When the patient reports a new symptom, it may be difficult to determine whether it is secondary to chemotherapy or it is due to concurrent medications or disease progression. Therefore, the clinician needs to be aware of the presentation, management, and prevention of the most common toxicities that will affect patients receiving chemotherapy. Now, in specific organ toxicities, first is neurotoxicity. Neurotoxicity is the toxicity related to brain. Neurotoxic side effects of chemotherapy occur frequently and are often a reason to limit the dose of chemotherapy. Chemotherapy may cause both peripheral neurotoxicity, consisting mainly of a peripheral neuropathy, and central neurotoxicity, ranging from minor cognitive deficits to encephalopathy with dementia or even coma. Patients who already have neuropathic symptoms due to diabetes mellitus, hereditary neuropathies, or the treatments which they were taking before neurotoxic chemotherapy can be the causes of this neurotoxicity. Now, the agents that produces CNS toxicities include methotrexate, fluorouracil, interferon alpha, interleukin-2, fludarabine, erythritamine, carmustine, procarbazine, fosfamide, and oxaliplatin. Recognition of neurotoxicity resulting from chemotherapy is often difficult because of comorbid conditions such as metastatic disease or other paraneoplastic syndromes, but it is important in assessing the need for potential dose modifications or even discontinuation of the agent. Now, continuing with cardiac toxicities. Cardiac toxicities is damage to the heart by harmful chemicals. It's like you are given toxins to kill cancer cells because they uh, also kill normal cells in and around your heart. The chemotherapy drugs that most commonly cause heart damage are anthracyclines. Anthracyclines are used to treat many types of cancers. Examples include leukemia, lymphoma, sarcomas that can be of bladder, bone, breast, head and neck, kidney, skin, stomach, and many other cancers. Anthracyclines include daunorubicin, doxorubicin, epirubicin, idarubicin, valrubicin, etc. In this case, the subject DA, a 35-year-old man with stage 4 Hodgkin's disease, is receiving CHOP, cyclophosphamide 750 mg per meter square IV day 1, doxorubicin 50 mg per meter square IV day 1, vincristine 2 mg IV day 1, and prednisone 100 mg per oral days 1 to 5, and concurrent radiation therapy to a large mediastinal mass. He comes to the clinic to receive his fifth cycle of CHOP and complains of tachycardia, shortness of breath, and a non-productive cough. Physical examination reveals neck, vein distension, pulmonary rales, and ankle edema. What is the most likely cause of DA's current symptoms? Now we'll start to understand this case first. The subject is experiencing symptoms of congestive heart failure, which is most likely caused by doxorubicin therapy. Doxorubicin is an anthracycline antibiotic which can cause dose-dependent cardiomyopathy that generally occurs with repeated administration. Now, the term dependent cardiomyopathy should be considered very carefully, that it means that cardiomyopathy is dose dependent. DA's presentation is fairly typical of doxorubicin-induced cardiomyopathy, although he has no significant risk factors usually associated with CHF. The total cumulative dose of doxorubicin is the main factor involved in CHF. Patients like DA who are receiving bolus doses of doxorubicin at the standard 3-week interval face little risk of CHF until a total dose of 450 mg per meter square to 550 mg per meter square has been reached. After a patient has reached this dose and the dose increases from 550 mg per meter square, then the risk of CHF rises rapidly. Hence, the probability of CHF in patients receiving a total dose of 1000 mg per meter square may be nearly 50%. The other factors that could increase DA's risk of development of doxorubicin cardiac toxicity include mediastinal radiation therapy, pre-existing cardiac disease, hypertension, and age. Concurrent chemotherapy agents like cyclophosphamide, etoposide, paclitaxel may also potentiate doxorubicin cardiac toxicity. Now, it is unusual that a 35-year-old man who has only received cumulative dose of 200 mg per meter square of doxorubicin would be presenting the symptoms of congestive heart failure. So we'll assume that mediastinal radiation therapy, cyclophosphamide, or maybe undiagnosed cardiac disease may, however, have contributed to this event. In addition to this, Hodgkin's disease also is involved in the deterioration or effect on myocardium. So we can also consider that Hodgkin's disease may also be responsible for this. Routine cardiac monitoring of doxorubicin, which is necessary to prevent CHF, and it is achieved by primarily limiting the total cumulative dose, which cannot entirely prevent the cardiomyopathy for two reasons. First reason is that individual tolerance to doxorubicin varies, such that cardiotoxicity may occur before the arbitrary dose. Second reason is that some clinical situations warrant exceeds the dose limit to achieve positive chemotherapeutic outcomes. Radionuclide ventriculography and endomyocardial biopsy are complementary procedures that, when used together with clinical evaluation, can provide a degree of confidence in predicting tolerance to additional doxorubicin dosing. The endomyocardial biopsy provides a distinct advantage by allowing early myocyte damage to be appreciated before the RNV changes or the patient shows signs of CHF. Now, the prevention of cardiac toxicity is achieved by altering the dose schedule of doxorubicin to more frequent and smaller doses, while maintaining dose intensity has consistently resulted in reduction of cardiac toxicity. Low doses of doxorubicin administered weekly or prolonged continuous IV infusions can be relatively cardiac sparing, allowing higher cumulative doses to be administered. The concurrent use of drugs that might minimize the risk of cardiotoxicity without compromising efficacy can also be considered, like dexrazoxane is a chemoprotectant that reduces the incidence and severity of cardiomyopathy. Another approach can be the encapsulation of the drug in liposomes. The management of congestive heart failure. Anthracycline-induced congestive heart failure should be treated with diuretics, activity restriction, inotropic agents, and vasodilators. The clinical course varies, with some patients showing stable disease and others showing improvement. Enalapril was evaluated to determine if it would prevent cardiac function decline in a randomized, double-blind, placebo-controlled study. Patients received enalapril at 0.05 mg per kg per day, and this dose was progressively escalated to 0.10 mg per kg per day and finally 0.15 mg per kg per day if there were no side effects. Side effects included dizziness, hypotension, and fatigue. Other agents involved in cardiac toxicities are fluorouracil alkylating agents, trastuzumab, multi-targeted tyrosine kinase inhibitors, monoclonal antibodies, etc. Now the third is hepatotoxicity. Hepatotoxicity is the elevated LFT occur frequently in cancer patients, and their causes are uh, listed below. Primary and metastatic tumor involvement of the liver, hepatotoxic drugs that can be cytotoxin hormones, estrogens, androgens, antimicrobials, infections, parenteral nutrition, portal vein thrombosis, paraneoplastic syndrome, and history of the liver disease, including hepatitis B and C. Signs and symptoms which are common are jaundice, nausea, vomiting, abdominal pain, and encephalopathy. The exact mechanisms by which chemotherapy agents cause hepatotoxicity are unknown, but most agents probably cause hepatic damage by interfering with the mitochondrial function of the hepatocyte, depleting hepatic glutathione stores, eliciting hypersensitivity reactions, and decreasing bile flow. That's all from my side. Jazakallah.